Hello students, hope you all did your NEET exam in great manner. There could be few surprises, there could be few disappointments, but nevertheless, we should be able to recall all the questions and search the correct answers so that we'll not repeat the same mistake in next exam. Okay. Now we'll start with the ENT questions. The first question, some told that it was quite a surprise why they are asking like this. See, whenever any ENT faculty teaches the anatomy of middle ear, they will teach the shape of the middle ear bones, malleus, incus, stapes, and especially this incus is an important bone of all. Okay, so this incus bone shape is very important. Clear? So that's why they have asked the shape of. They have given the incus bone. They have asked to identify the incus bone. The bone that was given in the exam is incus. So incus, we'll straight away start with incus. Incus, the shape of the incus is anvil shape. So what is an anvil? So anvil is nothing but a iron podium that is used to give death sentence for pain. Death sentence for the imprisoned persons. Okay. So that is the actual meaning of the word anvil. Okay. What other things that we need to know? Short process of incus and long process of incus, as well as lenticular process of incus. Okay. See, I have told all these things in the form of a three-dimensional orientation. So I'm going to show you the three-dimensional orientation of malleus, incus, and stapes as well. So that will give you a good idea about the malleus, incus, and stapes orientation and the important shape and surgical anatomy. Okay. So first we'll finish up some theory part. Malleus is the shape of hammer. Stapes has the shape of stirrup. Okay. So how you could have identified this bone in the exam? First, you think of the shape. Second thing, you can think of the processes. This is long process, lenticular process, short process. Okay. So these three processes should have come to your mind while identifying this bone as incus. Many would have confused yourselves with malleus. Okay. Malleus clearly has an anterior process. The head, the shape of the malleus will be like hammer. Okay. That should have given you a clear bit of idea about to differentiate between malleus and incus. Okay. Now let's go to the three-dimensional anatomy. Okay. So the three-dimensional anatomy, I'm going to show how the malleus, incus, and stapes are organized inside the middle ear. So I have already showed you this in class. See, this is malleus, this is incus, this is stapes. Okay. So this shape has particular value because that will define the important surgical anatomy of these particular structures. Okay, I have already told you the important surgical anatomy of our malleus, incus, and stapes. Okay, malleus is in connection with the tympanic membrane. Malleus is in connection with tympanic membrane. So how it is connected with tympanic membrane is to be seen. First, we'll introduce the other connective tissue structures so that we will get the attachment of malleus with the surrounding structures. See here. Okay, fine. So this is the cartilage. Okay. This is the orientation of malleus with that of tympanic membrane. So this is our tympanic membrane. This is our malleus. Now we should be knowing a little bit about the spaces that are associated with these structures. See here, just over here, you will be seeing a space called Cruzak Space. I have given a clear description about this space. So when you are learning about ossicles, you should be learning about these Cruzak space also. Okay. Now, slow. Inquido-malleolar joint. This inquido-malleolar joint is very important. Okay. This inquido-malleolar joint is a saddle type of joint. Okay. Then, what are the important things that are associated with incus and stapes? See here. This is the relation between incus and stapes. This is called inquido-stapetal joint. Inquido-stapetal joint is ball and socket variety of joint. Okay. So now if they ask you any important structure, again from the middle ear, you should be able to answer. First, incus, short process, long process. Here there will be some lenticular process. Malleus, handle of malleus, head of malleus, neck of malleus. So identification wise, this should be very clear in your mind. Okay. Stapes, again, head of stapes, neck of stapes, then anterior and posterior crura, anterior and posterior crura. Clear? Yes. That should sum it up the important anatomy that is associated with the three ossicles of the middle ear. Okay. Now, as they have asked you about the incus bone, you should be also knowing about the incus while doing a surgical procedure. Okay, while doing a surgical procedure. See, while we do a surgery called cochlear implant,
hearing device to restore hearing to patients who have severe to profound hearing loss.
See, this is a surgery.
The procedure begins by performing a mastoidectomy accomplished by removing the hollow bone behind the ear.
Temporal bone, so that we could reach a structure
after making an incision and retracting the ear forward to expose the mastoid bone surface, the honeycomb partitions of the mastoid tympani nerve, which supplies sense of taste to the facial, which is responsible for facial movements.
And see above, there is a, see, this middle ear bone is nothing but short process of incus that is seen from behind the ear.
The round window is where the implant will be inserted.
Orientation of ossicles from the middle ear. Now I am showing the short process of incus.
Once the round window is exposed, a well along with a channel are then drilled into the skull upon which the implant is seated.
Short process of incus above, facial nerve medially, and chorda tympani laterally.
The electrode array is then inserted into the round window and gently threaded into the cochlea. We can
insert the electrodes in cochlear implant so that we could reach the round window. This is how the electrodes are inserted through the facial recess, reaching the round window in cochlear implant surgery. So if you are studying about any ossicle, you should be clear with the important surgical anatomy of that particular ossicle. Malleus, Cruzak space, incus while doing cochlear implant, short process of incus is very important. Stapes, it is opening into the old window. So these three things that should be very clear while learning about these three particular ossicles. Okay, that should have made you clear about the ossicles and the important surgical anatomy. Next question again from otology. 6 years old boy with 2 months of diminished hearing and his mother took him to the hospital. Otoscopy picture is given. See, the otoscopy picture is very clear. You could see intact tympanic membrane. That is number 1. Then you could see air bubbles behind the intact tympanic membrane. Okay, you could see air bubbles behind the intact tympanic membrane. So let's read it out the options. First, otitis media with effusion. It could be, yes, that is the correct answer. Then what about otosclerosis? All these structures will be having intact tympanic membrane. That is an important clue that I've given. Okay. Then how you could differentiate between these? Otosclerosis. Otosclerosis, what you could see? You could see a vascular mask behind intact tympanic membrane, behind intactium, that is Schwartz sign. Okay, so that is whether that is seen. No, that is not seen. Schwartz sign is not seen here, so that is not otosclerosis. What is pneumotympanum? Pneumotympanum is nothing but air-filled middle ear cavity. So whether that is here? No. You could see air as well as water, so that is not pneumotympanum. Then meningitis bullosa. Meningitis bullosa is nothing but inflammation of the tympanic membrane. It will be some granular appearance. Okay, so meningitis is nothing but inflammation of the tympanic membrane alone. You could not see air bubbles like this. So again, it is not meningitis bullosa. The answer is otitis media with effusion. We can see otitis media effusion is otherwise called serous otitis media or blue ear or blue ear. These are the other names that you could know for otitis media with effusion. We call it as OME. Okay, now, so what are the causes for otitis media with effusion? See, we are having a middle ear. This middle ear is connected to the nasopharynx with the help of the eustachian tube. Clear? So this eustachian tube will maintain the pressure of the middle ear. Okay. So while doing so, if there is some obstruction at the pharyngeal end of the tympanopharyngeal tube, that is eustachian tube, there could be failure of maintaining the pressure of the middle ear. Okay, if there is a mass obstructing, or if there is some eustachian tube dysfunction at the pharyngeal end of the eustachian tube, you could get serous fluid filling the middle ear. That is serous otitis media. Okay, see, if there is an eustachian tube dysfunction. Okay. Or some mass like adenoid hypertrophy, or in adults, adenoid hypertrophy in children. If it occurs in adults, you should suspect carcinoma nasopharynx. Carcinoma nasopharynx. Yes. So these are the causes for serous otitis media. There is a blockage at the pharyngeal end of the eustachian tube that is causing serous and sterile fluid accumulating inside the middle ear. That is the causes for serous otitis media. See, that is blue ear. Okay. What is the tympanometry? Tympanometry is nothing but impedance audiometry. What is the impedance audiometry findings of the serous otitis media? I have told you, first it will start with eustachian tube dysfunction. That will be the first step in this disease. Then only there will be frank fluid. So if there is eustachian tube dysfunction, there is negative pressure inside the middle ear. If there is negative pressure inside the middle ear, you call it as C curve. Call it as C curve. So earlier part of this is you will be having C curve in tympanometry. Then there will be fluid filled middle ear. So it will be flat curve, that is B curve. So you may ask, both C curves and B curves are possible in serous otitis media. At early stages, we will be getting eustachian tube dysfunction alone. That time we will be getting C curve. Later, when the fluid fills the middle ear, we will be getting the B type of curve. That is the two types of curves that you will get in impedance audiometry findings of serous auditis media. Okay. So what else you could get some conductive hearing loss. Conductive hearing loss in audiogram. Yes. So most common cause of deafness in children. What could be the treatment? First, you should treat the cause. What is the cause? If it is eustachian tube dysfunction, okay, ask him to do some eustachian tube exercises such as Valsalva. Okay, so it is very early stage only, but if it is not effective for adenoid hypertrophy, you should do adenoidectomy or previously antibiotics. So either you can cure by antibiotics or you can do an adenoidectomy. Adenoidectomy should be associated with grommet insertion. See here, if this child is having adenoid hypertrophy associated with serous auditis media, you should do adenoidectomy as well as grommet insertion. Clear? So that should be the two treatment protocols for a child having serous auditis media due to adenoid hypertrophy. Clear? Yes. Now, if it is CA nasopharynx in adults, do you want to treat the serous auditis media? No. You should treat the nasopharynx by taking biopsy and plan for radiotherapy. That should be the treatment protocol for carcinoma nasopharynx. Okay, so serous auditis media, it is per se not a unified treatment. Based on the cause, you should treat the patient. Okay, that explains the serous auditis media. It's an important MCQ point of view that has been asked in this NEET exam. That question. See, the person with high frequency hearing loss, affected area close to. See, so basically, this is the cochlea. Clear? This is the basal tone. This is the apical tone. Clear? For this question, the straight answer would be for high frequency hearing loss, which is involved basal tone of cochlea. Okay, but the structures and parts of the internet that has been given here, we should find an answer out of these. Okay, first we'll see about what is stria vascularis. Stria vascularis is nothing but it is found within the scala media. It is found within scala media. So whether this will mention the basal tone? No, it is common for all. So the answer can't be stria vascularis. Okay. So what is helicotrauma? So the transition between the scala vestibuli and scala tympani, the area over here, we can call it as helicotrauma. So whether this area will be closer to the basal tone? No, helicotrauma can't be the answer. Then there will be an oval window. There will be an oval window over here. There will be a round window over here. Whether the oval window can be the area near to the basal tone, again it can't be. So I think the basal tone could be near to the modulus. Okay, so the answer is not crystal clear in this question. So I hope the options are same. I have verified with many students. So if these are the options that has been given, modulus will be the single best answer for this particular question. Clear? 18 years old male with recurrent episodes of epistaxis and nasal obstruction since 1 year. On examination, mass seen covering the posterior poina nasopharynx like this. Okay, fine. So if this is the case, what are the options? Rhinosporidiosis, rhinophyma, JNA, and foreign body nose. There are many positive findings for this particular diagnosis. First one is 18 years, then recurrent episodes of epistaxis, then nasopharyngeal mass. These 3 points will make us to think about JNA. So nothing but juvenile nasopharyngeal angiofibroma. Clear? Now, some important points about juvenile nasopharyngeal angiofibroma. So what could be the presentation? Adolescent males with recurrent epistaxis. Adolescent males, okay, around 10 to 18 years with recurrent epistaxis. Okay, so this could be the main clinical presentation for JN. Why it is happening more in male adolescents? Because of the hormone testosterone. Okay, testosterone hormone is the important cause that is making the recurrent epistaxis in JNA. Okay. So endoscopically you can examine the patient, you could finalize the diagnosis. How could you stage the tumor? Staging can be done by Radkowski. Staging is Radkowski staging. Okay. So 1A and 1B. Which is the most common site of JNA? The most common site of JNA is sphenopalatine foramen. Okay, sphenopalatine foramen. So 1A is just within the reach of nasopharynx. Okay, it is just within the reach of nasopharynx. It could reach the paranasal sinuses. This too is entirely pterygopalatine fossa. Pterygopalatine fossa. See here, this is the pterygopalatine fossa. This pterygopalatine fossa is lateral to the nasal cavity. Then it is medial to the infratemporal fossa. It is associated with nasal cavity, or it connects to the nasal cavity through the sphenopalatine foramen. Okay. It is connecting with the infratemporal fossa through the pterygomaxillary fissure. So this is the pterygopalatine fossa. Okay. Medially, it is connecting with the nasal cavity with the help of sphenopalatine foramen. Laterally, it is connecting with the infratemporal fossa with the pterygomaxillary fissure. Okay, so this is the important surgical anatomy of this pterygopalatine fossa. So if it is only 1/3 of the pterygopalatine fossa, it is 2A. More than half of pterygopalatine fossa, it is 2B. Complete occupying tumor of pterygopalatine fossa is 2C. Clear? Now, what about 3? 3A is involvement of infratemporal fossa. 3B is cranium. How cranium? This pterygopalatine fossa has posterior boundary that is related with foramen rotundum and pterygoid canal. Through that, it can enter easily into the cranium. So that's how the JNA is very important. It is a highly vascular tumor. Highly vascular. Okay. So that never take biopsy. Never take biopsy if you suspect JNA. Okay. Never take biopsy if you suspect JNA. Clear? So what are the imaging signs? See, this is the pterygopalatine fossa which is having the JNA. As the pterygopalatine fossa is found posterior to the maxillary bone. Posterior to the maxillary bone is pushing the posterior wall of maxilla. That is called Holman-Miller sign. Holman-Miller sign. Okay, it is an important sign that you could see. Again, The appearance of the child will be like frog. So it is frog face deformity will be there. See, this is a CT sign. This is an external appearance sign. Frog face deformity. These are important clinical points relevant to the JNA. How will you again investigate? You should do a 4-vessel angiography. You do a 4-vessel angiography. What is the treatment? Surgery is the best treatment for JNA. Okay, as it is a benign tumor, we should do surgery for this patient either by transpalatal with sublabial approach, that is Sardana approach. Clear? Transmaxillary approach. If it is a smaller mass, you could just do a transnasal approach. These are the approaches through which you could approach the nasopharynx having the juvenile nasopharyngeal angiofibroma and remove the mass. Okay, so the surgical approaches are very important that they may ask. Okay, the last question that has been asked in ENT is, which of the following is not a part of Samter stride? Okay, Samter stride is basically for aspirin related sensitivity with asthma and nasal polyps. So this is the description of Samter stride. Okay, so I hope most of you answered this correctly. So which is not a part of Samter stride? This is a part, this is a part, this is a part. Acetaminophen sensitivity is not a part of Samter stride. Okay, so Samter stride is nothing but aspirin related sensitivity that is causing an airway response as well as nasal way response. That is a Samter stride. Okay, so this is an easy question. Hope most of you have answered correctly. So this NEET question mostly it is clinical. Though you know the disease pattern, though you know the disease factual points, you should apply that clinically. You should be knowing the imaging part, you should be knowing the presentation part, and you should be knowing the surgical anatomy part. If you are clear with all these things, then only you could answer any question. Okay, so start studying in this manner, not only the factual points. If, for example, I'll take the JNA. So if you know the points of the JNA, it is not enough. So where it is happening, sphenopalatine foramen is present at the junction of nasal cavity and tracheopalatine fossa. You should be knowing the surface anatomy of and surgical anatomy of tracheopalatine fossa. You should study that with the help of the anatomy book also. In anatomy, you will be studying 4 ganglions. So while studying that, if you club that with this, you could easily mix and match and correlate important clinical points. Okay, never study a subject single-handedly. Always mix a subject with another subject. If you study ENT, you should be studying with anatomy also. Okay, you should be studying with surgery also. Then only you could easily correlate and you could study many important topics in a particular time frame itself. Okay, so this ENT part is quite easy only. I hope most of you have answered correctly. So study well, don't repeat the mistakes in the next exam. All the best.